Can everybody see that? Because I can't see anybody anymore.
Yes.
Excellent. Okay, so I'll just minimize you. There we are. Yes, so thank you very much for having me. I'm delighted to be here to talk about like basically one of my favorite topics, which is the role of social touch in pain. As Alison said, I'm a psychologist and a neuroscientist. So when you're talking about touch in relation to pain, lots of different professions and professionals can give really interesting insights. And I'm going to focus on the psychological and the neuroscientific literature today. So what I'm hoping to do is first convince you of the benefits of touch for social connection in general. And then I'll tell you about some studies that have looked at the effects of touch and interpersonal touch on pain in acute pain, it's mostly experimental studies. And then I'm going to finish with thinking about chronic pain and what we know about social touch in chronic pain and what we need to find out. All right, so I can move slides, that would help. Here we go. So I always like to start with a slide, and hopefully nobody needs convincing of the importance of social connection, but I think it's worth just taking a minute to think about it. So as humans, our experience is inextricably embedded within a social world. From the moment that we're born, we rely on others to keep us alive. And these relationships with our caregivers, later with our partners, with healthcare professionals, they all shape how we learn about pain, how we think about pain. And social connection and social support in particular is really crucial for help and provision of support in the face of threats in general. So there is quite a lot of literature on social support for stress, for example, but also for pain in particular. And when I first came to this topic, the social interactions and pain have been much less researched than, for example, the influence of social interactions on stress. But a lot of research has been done in this area in the last 10, 15 years or so. So as I said, when we're born pretty much completely helpless. We rely on others for care much longer than other mammals do. And so forming a stable bond with a caregiver is pretty much the first and most fundamental thing that we need to do. And we do this through social proximity, through keeping them close. And we need to keep them close so that our caregivers can feed us, clothe us, regulate our temperature through those ways, and also soothe our pain. And so how we think and learn about pain is really tied up with other people from the word go. And across the lifespan, we continue to rely on other people and to learn from other people about pain. For example, everyone who has a child who's fallen over in the playground will know that there's that split second where they look to you in order to interpret kind of the magnitude of what's just happened. And how we respond to that will shape how they learn about pain. And so to keep, we tend to seek this kind of social proximity from people who will help us keep us safe and look after us in times of threat. And these tend to be our caregivers early in life, and then later on in life, they're often our romantic partner, or what sometimes in psychology we would call attachment relationships. So people we feel close to, people we trust, people who make us feel safe. And the most fundamental way in which we can seek social proximity in times of threat is through touch. So we can't get any closer than touch. And I'm just going to hopefully convince you of the power of touch over the next couple of slides. So fundamentally, when we're seeking closeness and support from others, we do so through touch. And there are lots of different ways to touch. And I would just like you to do a really brief thought experiment. And I'd just like you to imagine that somebody in front of you is upset and you would like to comfort them through touch. So just take a few seconds to consider how you might do that. So there are lots of different things you might have thought about. You might have thought about squeezing their hand, rubbing their back, or patting their arm, or holding their hand. And there is a certain type of touch that's been studied extensively now in psychology and neuroscience that seems to be especially beneficial for signaling both support, love, and connection, and also for reducing pain, as we shall see. And that is this kind of slow velocity, gentle stroking, caressing touch. Some of you might be familiar with this. It's called affective touch or CT optimal touch or interoceptive touch. But for those of you who are less familiar, I'm just going to give you a quick overview. So the kind of touch that we're thinking about is this. It's gentle stroking caress, low pressure. So it's not like a massage, more of a gentle stroking. And we can contrast that in studies with faster velocity touch that looks like this. And so these two touches differ only really in terms of their velocity, but they also differ in terms of their underlying physiological properties. So I just want to spend a second talking about that, because that's important for the kind of underlying neurophysiological mechanisms of how pleasantness of touch and social connection are transmitted or mediated. So this kind of slow velocity affective touch, it's a specific type of dynamic caress-like touch, and this is especially important in initiating and maintaining social bonds. And interestingly, there have been lots of studies now that have showed that when you ask mothers to spontaneously stroke their babies, they do so at these gentle, slow speeds, and in adult intimate interactions as well. There's something about this slow velocity touch that we naturally will engage in slow, gentle stroking touch rather than this faster touch. And physiologically, this touch is really interesting. So if you stroke the skin at this slow velocity touch, it activates a class of unmyelinated, slow conducting C-tactile afferent fibers. And several studies, and this is the seminal study here on the left, have shown that you see a kind of inverted U-shaped curve for the firing rate of these fibers. So at these slow speeds, CT fibers optimally fire. And interestingly, this correlates very well with the subjective pleasantness of the touch. So this slow velocity touch, which optimally activates CT fibers, is also felt as most pleasant. So what we have here is kind of a physiological mechanism by which the slow, gentle stroking touch can feel pleasant. And this slow, gentle touch is associated with mu opioid activity and also oxytocin release, and brain regions that are implicated in interoceptive processing. So pain has also been thought of an interoceptive modality in neuroscience research, so just keep that in mind. And this kind of CT optimal touch, the slow velocity touch here, this can be contrasted with the faster touch I showed you just now, which doesn't optimally activate the CT fibers and is usually, I say usually because we know a lot now about individual differences and certain populations, but usually it's perceived as more effectively neutral. So in psychology or neuroscience, we have a nice control condition here. We can touch people, we can stroke people, and just vary the speed. By doing so, we also vary how much C-tactile afferents are activated and how pleasant that feels. Okay, so we're going to spend a bit of time talking about this particular touch, but I will broaden it back out to hugs, hand-holding, other forms of social touch. Now, touch has lots of different functions, but when we're thinking about this affective touch, there are two ways of sort of conceptualizing things. We can think about touch as having effects on our well-being, so it's an affecting model, such as modulating pain, as we'll see in a minute. But we can also think about touch as a non-verbal channel of communication and a way in which we can transmit certain messages to other people, for example, signaling our positive intentions towards them. And I'm just going to consider both of these in turn. So we'll start with the non-verbal effects, and we'll start, obviously, because this is a pain talk, about thinking about effects on acute pain. So a couple of studies in sort of more non-social settings have administered this slow, gentle touch, usually using a makeup brush, so not particularly ecologically valid, stroking the skin with a brush, a soft brush, and have found that that kind of slow, gentle stroking can indeed buffer against pain, so can reduce pain. But when I came to this topic, I thought that was missing the interpersonal dimension of touch. So my former PhD student, Mariana von Moore, asked couples to come into the lab who'd been together for longer than a year, and we trained the romantic partner to administer this slow, gentle touch compared to faster velocity touch. As I said, people tend to spontaneously choose these speeds, but we wanted to standardize it a little bit more. And we had the romantic partner administer these two different types of touches, and we recorded brain activity while they were doing that, as well as asking for participant self-report. These were healthy participants with no pre-existing pain conditions. So firstly, what we found was that the effective touch from the partner, this slow, gentle, usually pleasantly perceived touch, reduced subjective pain report. But interestingly, at the level of the brain, it also reduced pain-related neural processing. So in particular, this is what you see when you give people laser stimuli to the hand. You see a very quick deflection in the ongoing EEG. This is called the N170 or N1 sometimes, and indexes kind of the brain's first response to incoming noxious stimuli. And then you have a later N2, P2 biphasic component, which the amplitude of which usually is correlated with subjective pain intensity. So at the level of the brain, we also saw that effective touch buffered against the pain-related brain processing. So you can see here that the amplitude was reduced for our slow touch, the blue touch line here, in both these components. So we have some evidence that in experimentally induced pain, partner-delivered social touch can reduce pain experience and pain-related neural processing. And the way we've interpreted that is that, and I'll show you a nice model for that in a minute, but that touch essentially might reduce some of that unpleasant sensory salience of incoming painful stimuli, and it can signal the presence of an active or socially supportive environment, basically upping the perception of safety and downregulating the perception of threat. Here is a more formal model of what I've essentially just said, and it gives you some physiological mechanisms as well. So the only things I want to point out here is that there are two key ways in which this slow, gentle touch is thought to downregulate pain. One is a bottom-up mechanism. So as I said, it shares some interoceptive pathways with pain. And so one idea is that CT optimal touch can inhibit nociceptive input from progressing any further than the dorsal horn of the spinal cord. So it's kind of inhibiting this pain signal at this point. And the other, and not mutually exclusive explanation, is that areas of the brain that are involved with kind of the emotional evaluation of pain, and also with our ideas around what social support signals and means to us, can downregulate threat at higher order levels. So there is these two, and like I say, not mutually exclusive explanations for how slow, gentle touch might modulate pain in acute pain states. Okay. I said I'd also focus a little bit on other forms of touch. So before we move into chronic pain, just a little bit on, actually we have a few more slides before chronic pain, but just a bit on other forms of social touch. So in a more recent study has contrasted slow, gentle stroking touch with hand holding and the partner just being present. And they found that, again, it was experimentally induced pain. They found that all these kind of social touch conditions, and in fact, the partner merely being present, reduced pain compared to being on one's own. So they all seem to have some kind of a social signaling, social support sort of role. And they also took physiological measures and found that skin conductance rate was reduced in all these social support conditions as well. Interestingly, the social touch benefits were found only in women and not in men. And in general, there is not enough research looking at gender differences in these studies at all. And I'm partly guilty of that because we tend to recruit women because our experimenters are women if we're doing that. And so, yeah, we need more on gender differences. Okay, but the interesting thing as well was that all support conditions induced kind of synchrony, looking at skin conductance rate synchrony between partners. And this increased synchrony between partners was linked to lower pain intensity. So this is a kind of a nice mechanism as well. By boosting synchrony between partners, understanding between partners, this can downregulate pain in the person experiencing it as well. Again, in these experimental conditions. Okay, and just a last note on hand holding in particular, there's quite a lot of research on hand holding, and it can in general act as a buffer against both stress and pain, though what I would argue is sometimes the control conditions are a little bit weird. So in both of these studies here, they compared holding the hand of one spouse or partner to holding the hand of a stranger. And while there are some situations in which we might hold the hand of a stranger, in general, it's not particularly good comparison condition, I think. But in these studies, they tend to show that in this case, it was human touch and non-human touch. So in this Korisky study, it wasn't a stranger, it was like holding an object or sometimes it's holding a rubber hand. They found that the human touch was superior to that non-human touch in reducing pain. But the interesting thing about this study is actually the kind of hyperscanning element of it. So they looked at brain activation both in the person experiencing pain and in their romantic partner. And they found this interbrain coupling. So just thinking back to synchrony that we just saw at the skin conductance level, here we have synchrony in the interparietal lobule. And they argued that essentially what this is doing is that the person who's present, and in this case holding your hand during pain, is synchronizing their neural response to yours. And this in the person experiencing pain upregulates areas such as the medial prefrontal cortex, which in turn helps with emotion regulation. So I'm just mentioning this as some of the mechanisms that, psychology and neuroscience is starting to uncover some of the mechanisms by which other people being present and supportive during pain can enhance our own ability to deal with pain, and therefore, again, in experimental settings, affect how much pain we report. Okay, so that's the kind of affecting aspect of touch, but I also want to just spend a bit more time thinking about what touch can communicate. And we've done a few studies like that in my lab and with colleagues, where we've looked at the kinds of emotions and intentions that touch can communicate. And across many studies now, there's 3 studies here, we've shown that slow, gentle touch can reliably communicate love and support. So on the left-hand side here, we just stroked people at the CT optimal speeds or at faster speeds and asked them to kind of indicate what intention was being communicated purely through touch. There was no other verbal communication. And people generally picked a support intention for the slower touch and a kind of a warning intention for the faster touch, which I think is interesting because it's sort of an attention grabbing touch, which you can see here in some of this research as well. And then more recently, the middle panel here, we looked at a huge data set. So in 2020, the BBC Radio 4 Welcome Together collection, they ran a BBC touch test, which maybe you took part in. 40,000 adults in the UK took part. And we looked at what kinds of intentions and emotions people ascribe to these. In this case, it was gentle stroking touch and hugs. And you can see that overwhelmingly, again, support emerges as an intention that's ascribed to this kind of touch. Interestingly, when people have their partner in mind, this gentle touch is also linked to desire or kind of sexual arousal. So it has this role in building intimacy as well. Just a note, this is kind of progressing slowly into or thinking more, building the case for social connection. Touch can make others seem friendlier as well, especially when you couple it with neurotransmitters that have been linked to kind of social bonding and social connection, such as oxytocin. So this pro-social touch can communicate, support and love, can make others seem friendlier and more approachable, and can in general foster a positive connection. This is a nice study. I like this study because it's quite ecologically valid. So what they did here was looked at partners' amount of sleep touch in the night, and the amount of sleep touch predicted mood, happy, calm mood in both members of the couple in the morning. But even at the end of the day, it predicted had positive outcomes. So that, for example, wives, actually both wives and husbands reported more positive spousal events and more enjoyment in spending time with spouse. So it had this really important role in regulating mood, in signaling love and support, and just in fostering positive connection with one's partner. Okay, and just how might it do that? Well, I think it's important when we think about touch to think about it as being mutually rewarding for both parties. In studies, we often just study one member of the dyad receiving the touch, but actually in general, in daily life, obviously, there is a toucher and a touchee, and there's some research to suggest that touch is mutually rewarding. So, for example, there's a phenomenon called the social softness illusion that you rate, in general, we rate other people's skin as softer and smoother than our own skin, especially when we're stroking them at these slow CT optimal velocities. And here we can see that although being touched is the most pleasant, stroking somebody else is still more pleasant than stroking your own arm. So that there are rewards both in receiving touch and in giving touch. And this can be kind of create a mutually beneficial positive reinforcement cycle. Okay, so an interim summary on acute pain, and then I want to focus a bit more on chronic pain. So in acute or experimentally induced pain studies, social touch can reduce pain intensity and neural responses to pain, and physiological responses like skin conductance rate. There's interesting research now coming out on temporal summation of second pain as well, so kind of looking at experimental models of central sensitization and also showing that social touch can modulate that. But how does it do so? I've tried to pick up a few mechanisms that I just want to summarize. We have bottom-up inhibition, whereby nociceptive signals are kind of blocked at lower levels. We've got the role of endogenous opioids and oxytocin. and also parasympathetic nervous system activation. So in the study I just showed you with stroking, being stroked or self-stroking, they looked at heart rate as well as an index of that, and could see dampening of heart rate in social touch. It can also down-regulate areas such as the insular and anterior cingulate cortex, which are important for integrating pain signals or interoceptive signals more generally with our social, emotional, kind of cognitive processes higher up. It can improve mood, as we saw in the spousal enjoyment study. It can facilitate interpersonal synchronization, which can lead to things like greater empathic accuracy, kind of knowing more what your partner might need, and therefore improving your capacity to help. And it can also, as I showed you in that hand-holding study, upregulate emotion regulation skills in the person in pain. And lastly, it can really powerfully communicate pro-social intentions and lead to us perceiving other people as more approachable. So hold all of these things in mind. I hope this is my little pitch for how beneficial touch can be. But most studies are focused on acute and experimentally induced pain, where healthy participants with no pre-existing pain conditions come into the lab and experience these still relatively artificial paradigms. And by artificial, I mean most of the studies still use a brush to stroke the skin rather than even having just the partner use their hand. Partly that's because as experimental psychologists, we like control. And if you use a brush, you don't have problems like sweaty hands or cold skin or pressure that's being administered can be kept more constant. But of course, we need to think about all of this when we translate it into real life. So there has been a little bit of research on effective touch in chronic pain. In particular, do people with chronic pain find this kind of effective touch pleasant? And there's actually not much consistent literature, and the comparators also matter. So the kind of control conditions people choose and the kinds of things they choose to look at. I just want to show you 3 different studies, and then I'm also going to just say kind of maybe a little plea to sort of move away from thinking specifically about activation of C fibers and thinking more about the higher order psychological processes. So there is some evidence to suggest that overall touch across different velocities is less pleasant at pain sites in, for example, CRPS and PRN, which is post-herpetic neuropathy. But there was no difference here in healthy controls to a reference site. And I think this is kind of interesting. So if you stroke at sites that are painful, people with that pain condition will find it less pleasant. But if you pick a site where they don't usually experience pain, then actually people find it just as pleasant as people without chronic pain. Another study found that pleasantness for this slow, gentle touch was reduced in people with chronic low back pain compared to controls. But in this study, for example, they only looked at slow touch. We have no comparison with fast touch, so we don't know if this is actually specific to effective touch or to touch in general, or even if it's anything to do with the emotional valence of it. And they only had 6 trials. They did 6 individual strokes. I don't think this is particularly compelling evidence. There's also some research to show that slow touch is perceived as less pleasant in fibromyalgia compared to healthy controls. But interestingly, I wonder, do I have the slide? Let me show you. This is the slide to look at here. If you look at within the fibromyalgia group, they are still rating slow touch as more pleasant than fast touch. So overall, there is a bit of a dampening. But you see the pleasantness effect here, and you actually also see a pain effect here. That pain is slightly but significantly less after slow speeds than fast speeds. So you have to look quite carefully at the evidence and also how people interpret it. There's also some neural evidence that touch might be evaluated differently. So this is very early work. Some studies have found that you see the same regions activated in response to slow touch in people with and without chronic pain, but to a different degree, for example. So this is a bit of a messy literature at present, but I don't think it's completely compelling that people with chronic pain don't find effective touch pleasant. So I think there's a lot more going on here than these studies might suggest. It is true that we need to think about things like considering allodynia. So for example, if you have allodynia, you might find a slow, gentle stroke and touch unpleasant and painful. And here I just want to say that, of course, when you're thinking about touch and intervention or trying to promote touch, we would always tailor it to individual differences and preferences. And you would, of course, not administer touch if somebody finds it painful. So in considering allodynia, one thing that we can do is we can give people videos of touch to see, okay, in general, if they think about touch and if they see videos of touch, how do they rate that? Therefore, there's no sensory input. There is quite a lot of evidence to suggest in non-chronic pain populations that seeing touch activates similar regions in the brain as first-hand experience touch. So it's kind of a good proxy, and you don't have any sensory input here to contend with in terms of allodynia. So we recruited, this was myself and a student at University of Liverpool. We recruited quite a large sample of people with chronic pain and healthy comparison participants. We did make sure they were all currently in a relationship because we asked them about the touch in relation to a partner. And we asked them to rate different things about this touch, and also tapped into some self-reported individual differences, attachment style. This RASP measures like individual, wait, I might have a picture for that, individual attitudes and responses to support during pain catastrophizing, that sort of thing. I just want to do a little plug for my own measure. So this is the responses and attitudes to support during pain measure. And if you ever need a measure that just wants to find out how people, individual differences in terms of how they generally feel about support from their partner, pain behaviors when they are receiving partner support, how distraction by the partner. And there's also 2 health professional scales as well, tapping into emotional support and anxiety in the context of healthcare professionals, then do check out the measure. Free to use. I'm very happy if people use it. So we gave people that measure as well. Okay, so the first thing that we found was when you watch these videos, there's actually no evidence of reduced discrimination for effective touch and chronic pain, meaning they do still rate, this is the group, they rate the slow touch as significantly more pleasant than the fast touch. Interestingly, we didn't really see that difference in the healthy controls, but we did see it in the chronic pain participants. And participants with chronic pain also found the slow touch more comfortable and more pleasant, and they liked it more than the fast touch. And this was the same in healthy controls as well. And then we looked at some of the individual differences. And so liking touch was predicted by a general preference for partner support. And this is what I mean. You're going to tailor it to people who might benefit from it. These are people who generally feel positive about partner support. Also, people who hold more positive attitudes about intimate touch, and people who like distraction, but only when they are currently in pain. And these are people who experience chronic pain. This was our sample. And this is you can look at the group differences here. The only actual difference between the groups was in terms of liking. So the chronic pain population, or chronic pain sample, liked the touch, reported to like touch slightly less than our healthy comparison group, but everything else was comparable. So there's some evidence here that at the very least we need more research to untangle how people with chronic pain feel about slow, gentle stroking touch. But that notwithstanding, there are a couple of interventions that have started giving effective touch and looking at effects in chronic pain. And really interestingly, as I'll kind of say in a minute, they take the interpersonal dimension completely out of it. So, for example, in this study, people received slow, gentle touch by means of a machine. This is the right-hand side here. And the control condition was vibro-tactile sensations. So they don't activate CT fibers. It is also a type of touch. It's a good control condition, but you can see that, there's very little interpersonal dimension here. However, this kind of CT fiber stimulation did reduce pain, and this was naturally fluctuating kind of ongoing pain in a sample of people with quite varied chronic pain conditions. And here is another trial just to show in CRPS specifically, people were stroked with brushes twice daily for 10 minutes for 10 days. So quite an intensive study, and people came in for all of this. They didn't do this at home. And they found an effect only on kind of cold and warmth thresholds. So you can see that down here. These thresholds were kind of increased, but they didn't measure ongoing pain. So this was all part of quantitative sensory testing. So this kind of effective touch is being developed as an intervention for chronic pain. But I think that the interpersonal dimension is missing here, and this link back to social connection is missing. I'll kind of expand on that a little bit more. As I said, my disclaimer here is that I'm drawing on psychology and neuroscience literature, and if I was a physiotherapist, I might give you a slightly different talk. So I have focused mostly on these sorts of studies. Here's just one more to show you that this is kind of psychoregulatory massage therapy, they called it, and this is soft to moderate pressure, and the speeds are within the CT optimal range. And they found that compared to kind of classical massage therapy in a chronic pain sample, they saw improvements in mood. So just to show you another outcome, not looking at pain here, but looking at mood and looking at a slightly different way in which touch can be administered. It's arguably more interpersonal than the machine approach. Okay, I'm nearly done. So what is missing? I've kind of already alluded to it. I think all the research so far has been fairly bottom up, looking at CT fibers, looking at those sort of bottom up physiological mechanisms, and neglecting in chronic pain, not so much in acute experimental pain, but in chronic pain, kind of neglecting the top down. So what does it mean to people to be touched in slow, gentle ways, or in terms of hand holding, hugs, the rest of the social touch, when they're in chronic pain? How do people with chronic pain use touch on a day-to-day basis with loved ones? How do individual differences shape how much people like and want touch? We know very, very little about this so far. And as I said, there's kind of no social context to draw on really in the chronic pain study so far. So where is the interpersonal dimension? And I think this is really important to consider in chronic pain. And here are just two nice illustrative quotes that we know that social connection is often disrupted in chronic pain. So that this just shows kind of women in persistent pain kind of describe difficulties with emotional connectedness to others, which they can often attribute to their persistent pain. Or here, this is a nice study in which they gave people weighted blankets as an intervention for chronic pain. And they found that this kind of weighted blanket was a beneficial tool for people who were more prone to social disconnection. And they say that might activate embodied representations of safety and social support. That's kind of speculative at this point, but based on what we know from the experimental literature, neuroscientific literature, it's something that could be explored further. So it's cool, but it's still a blanket rather than a family member or a partner, for example. Okay, so here are some open questions. I think they've all come up so far. But really what we need to find out is what different types of touch mean to people with chronic pain. Do they communicate love and support in the same way as for people without chronic pain? And then for me, which is where I come into sort of the translation aspect of it, is, well, can we build an intervention that might comprise touch? It doesn't have to be just effective touch. That's where kind of the literature is very strong in the neuroscientific circles, but other forms of touch like hand holding and hugs as well, to promote interpersonal closeness in chronic pain. And can we take these individual differences into account? I would never advertise this as a one size fits all. I think, I've done a lot of work on individual differences. And while I've mostly shown you main effects today due to time constraints, that's something that definitely needs to be addressed. And then we need to consider sensory aspects around allodynia for sure. So work that we've done so far, and this is with Maria, who's here today as well, who's starting a PhD next week, is we've done some public and patient involvement. And we asked them about feelings around touch and also kind of about how they use it to foster social connectedness. And there were some really nice examples here. So they did say they use touch, but in general, not kind of just effective touch, any type of touch. And they said these were some really nice examples given. So touch from grandkids are soothing and unconditionally loving, non-judgmental, I think was the word. Or another example was somebody lying next to their daughter in pain, sending good thoughts. The partner stroking somebody to go to sleep. A lot was around sleep, actually, and difficulties getting to sleep, which is really important, I think, when we think about outcomes. Used as a relaxation or distraction tool during medical procedures, for example. Timing came out as a big issue, so everybody said no to touch on bad pain days. And this is something, again, which you would definitely need to take into account. It seems to kind of be a sweet spot or an optimal level at which touch might be beneficial. It was quite interesting that people said that being together but not touching was also kind of not being alone in it. So being spoken to and not touched. Obviously, this goes beyond just touch. And I guess what I've talked about today has very much been isolating touch from the rest of the sensory modalities. And that's because that's what we do as experimental psychologists. But of course, usually when we experience touch, it's not in a otherwise sensory vacuum. We're talking to people, for example. So it's kind of interesting to think about how to integrate all of that. And then, as I said, some key outcomes were actually not necessarily focusing on pain reduction, which is what most of the experimental and the chronic pain literature is focused on, but other outcomes such as getting to sleep and staying asleep and reducing some of the unpleasant effects that come with fatigue. So these are all things that we're going to be exploring. My next steps are to apply for a research for patient benefit grant. So this is very much in the works and hopefully to be submitted in March, to answer some of these open questions that I formulated today. This is not yet to run any kind of feasibility or acceptability study, but very much an intervention development phase to find out what people want, what might work. But with the ultimate goal to translate some of this basic science research from psychology and neuroscience into clinical settings. So I think that doesn't happen enough, that dialogue between these different areas of work. So I'd like to thank you very much for your attention today. Here are just some people who have been really helpful in conversations, in running studies and all the rest of it, and some funding from Uni of Liverpool and John Moores as well for some of this early work. So I'm going to stop sharing and thank you very much for your attention. And I can see you again, which is lovely.
So thank you for that, Charlotte. If we just open that up to any questions then, please. Has anybody got any questions for Charlotte? Christian?
Hi, can you hear me okay?
Yes. Yeah.
Thanks, Charlotte. That was really interesting. Yeah, I just had a few thoughts and questions, really. I mean, firstly, I remember a long time ago, I read a really interesting article that suggested sort of more insecure attachment styles meant that you are effectively more likely to struggle to adapt to and cope with chronic pain. I suppose that got me thinking about just broadly kind of when we're looking at samples of people with chronic pain, is there any chance that we may actually have more people that have some sort of insecure attachment? The other thing I was thinking was obviously coming back to the meaning of touch. There are obviously certain attachment styles where, for example, touch may even spark off someone's threat system. So I wondered if there'd been any research looking at these things. And then the other thought that popped in my mind was just widening this out, things like animals, like, has there been any research looking at, I was thinking even if it'd be interesting to look at, people that live alone, pet owners versus non-pet owners, and some of these really interesting differences, whether there's any way to look at the positive impact of even having a pet. So sorry, just a load of thoughts there.
No,
I just wondered what your thoughts were on them.
They're good questions and I have answers for all of them, which is fun. So I'll start with the pet one. It is interesting. So I had a colleague who ran a study looking at exactly that. So at stroking a pet, or being in the presence of a pet during pain compared to a friend or alone. And in fact, the greatest benefits in terms of pain were seen in the pet condition. And their interpretation was that the pets are non-judgmental, unconditionally loving. You don't have to work out the intention. So that there might be some kind of, takes out some of the perspective taking or mentalizing that you might otherwise have to do when you're in the presence of a friend. I think friend is always a bit of an ambiguous category as well. So that might not have helped. But yes, for pet ownership, there's a whole fascinating kind of research on what that sparks. But stroking your pet also releases oxytocin in the same way as stroking somebody else might do. So for sure, there are applications for pet ownership and pet stroking, and it's an interesting area. In terms of attachment, yes. So we have looked at that quite a bit, and you can find individual differences in how touch is perceived according to people's attachment styles. And interestingly, there seems to be reduced discriminability between different types of touch for more anxiously attached participants. And this means that they don't tend to rate the kind of slow, effective touch as more pleasant than the faster touch. They rate both as kind of similarly pleasant. And the idea behind that is that people who are more anxiously attached tend to crave social connection. So essentially, they are quite hypervigilant to threats, and they kind of engage in proximity seeking to a greater degree than people who are less anxious might do. And in that case, touch is a really powerful signal. They're attuned to it more, and it doesn't quite matter so much what type of touch it is, because all touch at the end of the day signals proximity. So for people who are more anxiously attached, we then also observed greater pain reducing effects as a result of touch in the lab compared to people who are not as anxiously attached. For avoidance, you tend to get the opposite pattern. So people who are more avoidantly attached tend to be slightly more, this is an oversimplification, but tend to be more self-reliant, essentially have learned that it's others are not that trustworthy or reliable, and they engage in kind of slightly more own processing of stuff rather than wanting to depend on others. And those kinds of people can find touch a bit intrusive. So that kind of interferes with their own preferred coping mechanism. So I definitely think this is in healthy volunteers, but like you say, there are lots of interesting models linking insecure attachment to the development of chronic pain through some social and some non-social mechanisms. So, for example, this hypervigilance to threat that you find in attachment anxiety will extend to hypervigilance to pain stimuli, for example, or pain sensations, but also in terms of the kind of social component as well. So if we're thinking about touch in clinical settings, I would always say think about attachment style as well. And yeah, I could do a whole nother talk on individual differences. So yeah, thanks for your questions.
Thank you.
We got any other questions for Charlotte? Katie? Oh, Katie, we're on mute.
Of course I am, always on mute. I was just saying that was a really interesting presentation, and you're very skilled at explaining complex neuroscientific concepts really clearly. So that was really helpful, and I get it. I really get it, what's underpinning this, and you can really see the direction that you want to head in with this. And I don't know whether you do have an answer to this or not, but just knowing what you know about the mechanisms behind everything, and then over to the end point, I guess, which you're trying to get to, which is how can we use this to help our patients? Do you have any whiffs of ideas of how you see this could work in clinical practice potentially, or how could we, you know, use this understanding? And I'm sure you're not going to start telling us to stroke all our patients, are you?
No. I mean, no. I think this kind of an intervention is best done with loved ones and people that you are close to, because of all the benefits and because of all kind of going back to the start of life. This sort of thing is linked to so close social bonds. So while there's undoubtedly benefits in close therapeutic relationships where, you know, like signaling support through stroking someone's arm can be helpful and so on, no, I wouldn't suggest that we now start stroking all the patients. But what I do see as important is, firstly, in terms of education. So when I've, even in our PPI events, just explaining these sort of neuropsychological neurophysiological principles underlying how we process touch is really interesting to people. So I think touch is sometimes thought of this like fuzzy social sciencey construct. And so even just saying, no, this is how your brain integrates incoming non-noxious sensory stimulation with everything else that's going on to have a potentially beneficial effect is really eye-opening for people. So I think there's kind of a kind of a psychoeducation component almost to it, to kind of say, look, these are the benefits of touch, and we know a lot about this, but not so much in chronic pain. And the other thing is, I think, to then encourage people to try that kind of thing and find out what works for them, because a nice side effect is that it will promote interpersonal closeness, because you will be trying this out with somebody that you know. And even if the touch might not be for you, hopefully, or even if you're kind of trying to calibrate what you like, when you like it, when you don't like it, I think it gets a dialogue starting on other kind of interpersonal mechanisms that are the psychological processes that can be kind of interesting to explore. So I sort of see it as a kind of like a community-based intervention, almost like just reaching people through tertiary pain services could be really helpful, I think, because that's where people come to when they really need help. But I would almost outsource it back into their lives. They should be exploring this in their daily life. And like the nice study that Roberts et al. Study with the sleep touch between spouses, I think that's really nice as well, to just kind of, you can show people the benefits that it can have over the longer term. It's a bit of a long-winded answer, essentially, because this is some of the stuff that I want to explore with this grant, to understand from people how they could see it fitting in. So these are some of the initial thoughts that I've had in conversation with our PPI panel, but this is exactly what we're going to try and find out with the grant. And I think that sleep as an outcome is going to be quite important, actually, rather than pain reduction and pain attenuation as well. So kind of thinking about what you'd be hoping to influence in terms of quality of life and in terms of pain management is an interesting thing to consider as well. the experimental neuroscientific literature is all about pain reduction. That's all they care about as an outcome. So that's what we've got to go on. Does that answer your question? Sorry, I feel like I rambled.
Yeah, no, that's brilliant. Thank you. It's given us something to think about. Thank you.
Thank you. Michelle?
Really, really interesting. And I wondered whether you'd had a look at, because of course, touch is a really important component of nursing practice. And it's a very, it's a different sort of touch completely, but there's a lot of literature around communicating compassion through touch, through therapeutic touch and nursing touch. So I just wondered if there was an element that you'd explored around that, the overlap between the nursing literature and the psychology literature.
Yeah, super interesting. I just heard a talk on that from somebody who works in palliative care. So that was really eye-opening, the role of touch in palliative care. So other people are exploring that much more than I am. I've come from, my background is basically sort of in interpersonal relationships. So that's why I kind of focus on partners more. But no, it is really interesting. And they, in nursing, I think you have to kind of untease what is kind of instrumental touch. So you have to touch a patient to be able to insert a cannula or something like that. So you have to untangle that kind of touch from that kind of affective or emotionally imbued touch a little bit, which is a bit more tricky, so methodologically. But for sure, it's a really fascinating area, and I think it's something I need to explore more. It's not my natural background, but having just also heard that talk, yeah, it's really interesting. And in palliative care especially, there's also some interesting research in dementia research when touch can transcend verbal communication. So there's that idea as well. So a kind of end stage of life or in states where people have dementia, you can use that as that extra non-verbal channel of communication. But that also comes with ethical issues, because you need to be aware of how much people like and respond to that touch. It can be a complicated area we need to be thinking about.
It's a really interesting area. There's a fair amount of literature around how nurses, the way that they create spaces to help people feel safe. And it's just making me think that how nurses use touch safely in that space to create, and there's in terms of pain and pain relieving environments and pain producing environments. There's literature in nursing about how we create both of those in ward areas.
I might email you if that's okay.
Yeah, so I'd be really interested to connect up.
Yeah, awesome. Yeah, that sounds really interesting. These spaces are really interesting to explore. They're so hard to get a handle on. I've been trying to read all into kind of interpersonal safety, but it's so hard to quantify. You know, it's
I had a master's student who did a metaethnography of the qualitative work around different surgical wards, around where pain relief was good and where it wasn't, and what the components. But it's massively complex. You're right, yeah. But really interesting.
Yeah. Oh, awesome. Thank you.
Thank you. Have we got any other questions for Charlotte? Charlotte, one of the things that I've just jotted down is, you just said at the beginning, sort of earlier on in the presentation, around most of the work can be done with women.
Yeah.
Is that in the same when it came to the ones with the chronic pain population as well?
No, I think they're more mixed, which is good. But on the other hand, their gender differences are still not always explored. So you either tend to have single gender samples or mixed gender or mixed sex samples, but not exploring gender differences. Okay. And I think the difficulty is always that as soon as you explore that, you need double the sample, so people don't do it.
Yeah.
But it's a problem, and I acknowledge it's a problem. And in the pain literature, it's really interesting. You start reading this paper, and then halfway through you find out, oh, it was only in women. But and I've been pulled up by a reviewer for that before. They said you have to put women in the title to kind of say where, and it's true. But there are all kinds of difficult interactions. That's sort of the problem, because you then have quite a lot of cultural and societal level things that play into it. So in the experimental literature, people will report different amounts of pain depending on whether the experimenter is of the same or the opposite gender. So for example, men tend to downplay their pain in the presence of a female experimenter. So you get those sorts of effects. So what tends to happen is that people try to eliminate those effects by just focusing on, okay, we have female experimenters, we'll have female participants. I think so, yeah, to answer your question, samples are more mixed in chronic pain, but they still don't explore these gender differences very much. I think it is important to do, though, because of these different sort of expectations, different ways in which people report pain, different ways in which people use touch. So women tend to be more susceptible to the effects of touch as well. They tend to find touch more pleasant. So there's, you know, there are definite things that need to be explored there as well. Sometimes just a pragmatic, unfortunately, like a power problem. Yeah.
Okay, thank you. Just before we finish then, any other questions or comments? No. Okay.
Oh, thanks for all the thought-provoking questions. Lots to think about.
And thank you for joining us today. Okay, thank you.
Oh,
Bye-bye.
thanks, everyone.
Bye-bye.
Oh, thanks, Charlotte. See you soon.
Thank you. Thanks.
Bye.
Bye.
Thank you.
Thanks, bye.
Bye.